Salam alaikum. It's the second part of this OBGA and GYN lecture 10 page at a row. This is the second part. First of all, PID, pelvic inflammatory disease. Patient comes with lower abdominal pain and abnormal bleeding. When a patient comes with a lower abdominal pain and abnormal bleeding, then we take a history. Mm, age, age, is it within 15 to 25? Does she has multiple sexual partner? Does she uses uh, inconsistent barrier contraception use, inconsistent barrier contraception use, or is there any previous PID partner with sexually transmitted infection? Physical examination, there may be fever, there may be the most important is cervical motion tenderness and mucopurulent discharge. So, so in PID, symptom is lower abdominal pain and abnormal bleeding with this risk factor and these physicals, mucopurulent discharge, cervical motion tenderness on cervical examination, treatment. If we think that the patient should be treated as outpatient management, then we should give IM ceftriaxone plus oral doxycycline. Doxycycline is a must. And for inpatient, IV cefotoxin plus cefotoxin plus oral doxycycline. The complication for PID is PITE. That means perihepatitis, infertility, ovarian abscess, and ectopic pregnancy. As PID is a polymicrobial infection of the upper GIT, uh, in here it these infection can ascend and can involve the uterus, fallopian tube. There is constant pelvic pain as the inflammation is spread throughout the peritoneal cavity. Infection information spread through the peritoneal cavity. It usually causes constant pain. It is diagnosed clinically, and broad spectrum antibiotic therapy should be given to prevent complication. Yeah, IUD removal is not a must because it can increase the risk of unintended pregnancy. It does not affect the treatment outcome. Indication for hospitalization if she's pregnant, if failed outpatient management, inability to tolerate oral medication, non-compliant with the therapy, if there is severe presentation like high fever, vomiting, and dehydration, and the complication ovarian abscess. Regimens for hospitalized patients include IV cefotaxime or cefotaxime plus oral doxycycline or parenteral IV clindamycin or gentamicin. As we know that doxycycline has anaerobic coverage, so doxycycline is enough. But if we think that there is tube ovarian abscess, for that coverage we should add metros. Tube ovarian abscess is a complication of pelvic inflammatory disease. It presents with fever, abdominal pain, and complex multinucleated adnexal mass with thick walls and internal debris on ultrasound. Labs, leukocytosis, C-reactive protein. If there is leukocytosis, increased C-reactive protein and CA125 with fever, it is either infection rather than malignancy. What malignancy can happen? Ovarian cyst, serous cyst, adenocarcinoma may happen. For this, broad spectrum antibiotics should be given. Actinomyces israeli actually causes oral infection. It's most common, but it can cause PID as it is a normal flora. As it is a normal flora, it can hasten and cause pelvic inflammatory disease. If it is asymptomatic actinomyces do not need treatment. But if symptomatic actinomyces, abnormal vaginal discharge and pelvic pain require iodine removal first. What you need to remove IOD, IOD removal along with empiric broad spectrum antibiotic for PID. PID. The IOD is sent for culture with positive actin-mysis culture, additional targeted treatment with penicillin. Penicillin is a must and additional treatment should be added. And these patients require iodine removal, culture, pelvic ultrasound, and prolonged penicillin therapy for more than 6 to 12 months. For more than 6 to 12 months. If there is pelvic mass abscess, they require this long-term penicillin therapy. Long-term penicillin therapy. Cervical culture is not typically performed because of a positive culture of actinomyces due to asymptomatic colonization. As it is a normal flora, it may be positive, but symptomatic patient with culture from the IUD is preferred rather than culture from the cervix. Acute cervicitis. It is infectious or non-infectious. Acute cervicitis may be infectious, usually Neisseria gonorrhoeae and chlamydia, and non-infectious, maybe foreign body, latex, or Dowsing. In here, there is mucopurulent discharge, postcoital or intermenstrual bleeding, and friable cervix. It may be asymptomatic also. NAT is the confirmatory test, and wet bond microscopy can be done as the infectious organism is specific, like Neisseria gonorrhoeae for Neisseria gonorrhoeae ceftriaxone, and for chlamydia azithromycin. So, empiric antibiotic is azithromycin plus ceftriaxone. Acute cervicitis can present with first trimester bleeding and mucopurulent endocervical discharge. In here, there is friable cervix, bleeds only, touch to contact, NAT test is a confirmatory. A common cause of first trimester bleeding. A common cause of first trimester bleeding is spontaneous abortion, and other etiologies ranges from benign cervical polyp. It is the most common cause of first trimester bleeding, and most common cause of spontaneous abortion, having spontaneous abortion. Another is cervical polyp to life-threatening ectopic pregnancy and septic abortion. Therefore, initial evaluation with speculum examination to determine the source of bleeding, and with pelvic ultrasonogram to determine the pregnancy location. Determine the pregnancy location. This is very, very important. Sexual assault. Sexual assault, physical or forensic examination. Here, semen should be evaluated and psychologically assessment should be done. Consequence is mental health disorder like PTSD can happen, unintended pregnancy can happen, and STD can happen. Unintended pregnancy, STD, mental health disorder like PTSD can happen. Post-exposure prophylaxis, emergency contraception, and psychological counseling should be must. For PTSD or other depressive illness, psychological counseling, emergency contraception for unwanted pregnancy, and post-exposure prophylaxis uh, should be given. For post-exposure prophylaxis, for chlamydia, azithromycin, for gonorrhea, ceftriaxone, for trichomonas, metronidazole for HIV, multi-drug regimen, tenofovir, emtricitabine with raltegravir, and hepatitis B vaccine and immunoglobulin should be given. Rape. Rape is a sexual assault. Mm, Assault involving unwanted vaginal oral penetration through force or lack of consent. Through force or lack of consent. This is rape. Unwanted vaginal, oral, or anal penetration. Through force or unwanted, through force or lack of consent. Date rape drugs like flunitrazepam that causes loss of consciousness and amnesia that causes alcohol can be used as an intoxication. Alcohol intoxication and date rape drugs like flunitrazepam that causes loss of consciousness and amnesia among adolescent and young adult. There are multiple cultural myths about date rape, including that it is not real rape, and that by agreeing to go home with a man or a woman is agreeing to sex. Because these myths, date rape victims are more likely to feel partially responsible for their assault, which can lead to long-term psychological consequences ranging from decreased appetite to sleep disturbance to PTSD and suicidality. So they are partially uh, they as their date rape um, is partially uh, the person, the woman or the person is personally partially responsible for this to happen. So they starts mm, they starts having some sort of psychological problem like PTSD, sleep disturbance, decreased appetite, and suicidality can be happen. So, in such cases, post-exposure prophylaxis, psychosocial counseling, and education should be done. Patient who seek care within 72 hours on an assault. Post-exposure prophylaxis for HIV is individualized after counseling the patient on the risk and benefit of the therapy. In addition, post-exposure prophylaxis to women with a negative pregnancy test are offered. Emergency contraception, oral levonorgestrel. Now, uh, now I would like to discuss about the vaginal problem. It starts with imperforate hymen. Incomplete degeneration of hymen is called imperforate hymen. In here there is cyclic lower abdominal pain, cyclic lower abdominal pain, bulk symptom, cyclic lower abdominal pain. There is symptoms like defecatory or urinary dysfunction. There may be primary amenorrhea. There may be suprapubic mass, blue tinged vaginal mass. There may be blue tinged vaginal mass is present. Hymenal incision and drainage should be done. Hymenal incision and drainage should be done. Girls with an imperfect hymen are typically asymptomatic until menarche, when they begin to have cyclical lower abdominal pain due to uterine cramping and obstructed menstruation. As blood volume in the vagina increases, hematocolpos, uh, the vagina and sometimes uterus become markedly distended, enlarged suprapubic mass causing bulk symptoms that include constant lower abdominal pain. Posterior expansion of the hematocolpos cause increased rectal pressure. Patient can present with defecatory pain, sense of incomplete evacuation, and a tender anterectal mass and a tender anterectal mass. Pelvic examination typically reveals a blue bulging vaginal mass is a blue bulging vaginal mass or membrane that swells with increased intra-abdominal pressure. Like Valsalva. If the pelvic mass and chronic pelvic pain do not resolve with incision and drainage, diagnostic laparoscopy should be performed to evaluate other pathology, endometriosis. And next, sarcoma botrytis is for it's a sarcoma botrytis is a form of rhabdomyosarcoma, polypoid grape-like mass protruding through the vagina, are usually in the babies less than age 3. Sarcoma or a grape-like mass protruding from the vagina with associated with vaginal discharge and bleeding. Now labial adhesion. In labial adhesion, labial adhesion or fused labia minora is most commonly seen in the prepubertal girls. Prepubertal girls, this is seen. Now the peak incidence age is age 2 to 3. In here, there is low estrogen production, inflammation from poor hygiene. One is low estrogen production, another one is inflammation due to poor hygiene, infection, vaginitis, and diaper rash can cause labial adhesion. And another is a trauma, straddle injury, also contributes for the development of these labial adhesion. A fused labia minoris, most commonly in the prepubertal age 2 to 3, due to trauma, due to inflammation from poor hygiene, due to low estrogen production, due to infection like vaginitis, due to diaper rash. It can be partial, involving the portion of the labia. It may be complete. Two types. It may be partial, it may be complete. Partial adhesion are asymptomatic. Some children develop pain or pruritus, which will lead to excoriation and exacerbate the adhesional development. But, adhesional covering the urethral meatus can also cause the abnormal urinary stream and increased risk of recurrent UTI. Mild asymptomatic labial adhesion require no treatment because up to 80% of the labial adhesion resolves spontaneously first line. However, in patients with complete adhesion or symptomatic partial adhesion, topical estrogen cream is just enough. So you have to know what is the main cause behind it. Labial adhesion due to poor estrogen, maybe due to other cause. So if there is other factors involved, correct the other factors. If there is diaper rash, treat accordingly. If there is poor hygiene, mm, you have to take care of that. But as it is due to low estrogen, so you can give topical estrogen. Candidal vulvovaginitis is a beefy red rash in the vulva as well as the vaginal pruritus and dishes as well as the vaginal pruritus and dishes. Contact dermatitis and lichen sclerosus is a type of skin inflammation that can predispose to labial adhesion. However, contact dermatitis present with pruritic erythematous rash, and lichen sclerosus is characterized by hypopigmented lesion. Lichen sclerosus, hypopigmented labial lesion, pinworm infection typically present with school age and perianal leaching, and particularly at the night, and urethral prolapse in the pre-pubertal girls with inflamed friable tissue in a donut shape at the urethral meatus. Urethral prolapse may be at a donut shape at the urethral meatus. Lichen sclerosus or vulval lichen sclerosus. Epidemiology of vulvar lichen sclerosus. Prepubertal girl and perimenopausal and postmenopausal woman. Prepubertal girl and perimenopausal or postmenopausal woman. Clinical feature is white, wrinkled thin, white, wrinkled skin over the labia majora or minora. There is thin, white, wrinkled skin above the labia majora and minora that may extend over the perineum and around the anus. Excoriation, erosion, fissure from severe pruritus may be seen. Dysuria, dyspareunia, and painful defecation, dysphagia may be present. In vaginal sclerosis, dysuria, dyspareunia, dysphagia may be present. Punch biopsy of adult onset lesion to exclude malignancy. Punch biopsy of adult onset lesion to exclude malignancy. Superpotent corticosteroid treatment should be given. Superpotent corticosteroid ointment should be given. It's a chronic inflammatory disease common in postmenopausal women, particularly in those with autoimmune disease, type 1 diabetes mellitus, alopecia areata. In early stages of the disease, the vulva thins, causing hypopigmented white areas and increasing in skin sensitivity that results in intense vulvar itching and burning associated with excoriation and erosions. There is white vulvar plaque lichenification, white vulvar plaque lichenification. In lichen sclerosis, lichenification, the word the white vulvar plaque is the masked and perianal skin thickening is a classic figure of 8 pattern. Perianal skin thickening in a classic figure of 8 pattern. In severe disease, normal anatomic structure may be obliterated or atrophied, leading to loss of the labia minora and clitoral head rotation, which can result in dyspareunia and urinary symptom, dysuria nocturia. In severe cases, normal anatomic structure may be obliterated or atrophied, such as loss of the labia minora and clitoral head, which can cause narrowing of the vaginal introitus and dyspareunia. Although lichen sclerosis can be diagnosed clinically, a vulvar punch biopsy is recommended to confirm the diagnosis. For diagnosis confirmation, what you have to do is to rule, what you have to do is to punch biopsy and rule out for vulvar cancer. Rule out for vulvar cancer, which can occur in patients with prolonged and persistent lichen sclerosis. First treatment for vulvar lichen sclerosis is super potent corticosteroid clobetasol, super potent clobetasol, which decreases the chronic inflammation and thereby improving the symptoms and potentially preventing the disease progression to vulvar intraepithelial neoplasia or vulvar cancer. So if you don't treat like sclerosis causes thickening and it can cause vulvar intraepithelial neoplasia and vulvar cancer if it is not being treated. So for confirmation cancer present or not, punch biopsy should be done for diagnosis, and the treatment is topical potent corticosteroid like clobetasol. Vaginal lichen planus. Lichen planus is very planar pruritic woman of 50-60, woman age of 50 and 60, vulvar pain or pruritus, dyspareunia, painful quietus, erosive variant, most common erosive glazed lesion with white butter, erosive glazed lesion with white butter, vaginal involvement and stenosis associated with oral ulcer. There is uh, and another variant is papillus variant, small pruritic papules with purple hue. Vulvar biopsy should be done to confirm. And high potency topical corticosteroid like clobetasol. In here you can also use clobetasol. So lichen planus, lichen sclerosus, treatment is all the same. High potency topical corticosteroid. Lichen sclerosis can present with valvar pruritus, white valvar plaque with associated erosion, valvar pruritus, and white valvar plaque, associated with erosion. However, lichen sclerosis typically have no vaginal involvement. Genital syndrome of menopause, like post-menopausal symptom, what we can say in a short. Genital syndrome, there is dyspareunia, there is vaginal bleeding, there is urinary incontinence, there is vulvovaginal dryness, irritation, pruritus, and recurrent urinary tract and recurrent urinary tract infection and pelvic pressure. On physical examination, you should do narrow. In physical examination, there is narrow enteritis, pale mucosa, decreased rugae, decreased elasticity, patchy fissures, petechiae fissures, and loss of labial volume. So, narrow enteritis, pale mucosa, decreased elasticity, decreased rugae, petechiae fissures, loss of labial volume. Treatment is vaginal moisturizer and lubricant can be used. Topical vaginal estrogen can be used. In atrophic vaginitis, in genitourinary syndrome of the menopause is due to low estrogen is due to atrophic vaginitis is due to low estrogen which causes decreased vulvovaginal tissue in the which causes decreased vulvovaginal tissue elasticity and blood flow. Physical examination include pale, easily denuded, retracted, atrophied vulvovaginal epithelium, clitoral shrinkage, and spare the diagnosis is made clinically. These diagnosis is made clinically. However, elevated vaginal pH more than 5 help to confirm the hypoestrogenic state because of reduced glycogen production. From reduced glycogen production, reduced elevated vaginal pH more than 5 help to confirm the hypoestrogenic state because reduced glycogen production reduces normal vaginal lactobacilli activity. Both age-related ovarian follicle depression, both age-related follicle distribution, both age-related ovarian follicle depletion, menopause, and surgical removal of the ovaries, bilateral salpingophractomy result in estrogen deficiency. These two cases, menopause and surgical removal of the BSO, result in estrogen deficiency that affects the urogenital tissue, causes the associated urinary symptoms of the atrophic vaginitis. There is decreased collagen and decreased glycogen content. Decreased collagen, decreased elasticity and blood flow in the bladder, trigone, and urethra. Decreased collagen, decreased elasticity, and blood flow to the bladder, trigone, and urethra result in urogenital atrophy, which can induce urogenital incontinence, often causing wet undergarment, wet undergarments and nocturia. Decreased glycogen content results in loss of vaginal lactobacilli and elevated vaginal pH, which increases the risk for recurrent UTI. At the vulva, decreased glycogen content at the vulva decreased glycogen content result in result in thin, easily degenerated vulvovaginal epithelium and cause dysuria, which when in contact with the urine. It causes dysuria when in contact with the urine. So decreased glycogen content and decreased collagen elasticity blood flow results in urogenital atrophy. First line treatment over the counter lubricants, moisturizer, vaginal estrogen is used to prevent is used persistent and severe symptoms. In contrast to atopic vaginal lichen sclerosis does not affect the vagina. In atopic vaginitis affect the vagina, but lichen sclerosis does not affect the vagina. Genitopelvic genitopelvic pain or penetration disorder due to sexual trauma, lack of sexual knowledge, and history of abuse. Pain with vaginal penetration, distress, or anxiety over the symptom, no other medical issue. Desensitization therapy and Kegel exercise. Desensitization therapy and Kegel exercise. In genitourinary pain or penetration disorder, there is desensitization therapy and Kegel exercise. Kegel exercise. Vaginismus. Vaginismus is a genitopelvic pain or penetration disorder is dyspareunia due to muscle spasm that mm, is due to muscle spasm that prevents vaginal penetration. Pelvic examination demonstrate involuntary muscle contraction that must be but may be limited as muscle spasm may prevent speculum entry, previously known as vaginismus. Genitopelvic pain or penetration disorder known as vaginismus, characterized by pain or on an aversion attempted to vaginal penetration. It can cause pain while penetration. It may be limited to primarily to the sexual content or include pain with tampon insertion, or genital or gynecological examination. It can cause pain. Examination differentiate it from other pathology like infectious vaginitis, vulvodynia, but may be limited as patient cannot tolerate uh, speculum insertion. Treatment is aimed as relaxation of vaginal muscle desensitization therapy treatment. Patients with vaginismus are treated with multiple modalities include CVT, couple therapy and sex education, pelvic floor physical therapy, pelvic floor physical therapy and vaginal dilator can be used. Atopic vaginitis may uh, present with entry dyspareunia, thinning mucosa, and a narrow vaginal nephritis. This is unlikely in a premenopausal patient. It is unlikely. Atopic vaginitis is very, very, very unlikely in premenopausal women. In postmenopausal women, usually atopic vaginitis is seen. Endometriosis may cause deep dyspareunia, but not insertional vaginal comfort. If there is insertional vaginal comfort, entry dyspareunia, it is must know atopic vaginitis. Localized provoked vulvodynia, formerly known as vestibulodynia, is pain to superficial touch to the vestibule. Is a very pain to superficial touch to the vestibule. There is an tenderness to touch on there is tenderness to touch on external examination. Vulvodynia causes dyspareunia due to sharp burning pain on the vulvar vestibule, often triggered to touch. Positive Q-tip test. Patient may have vestibular erythema, but no associated vaginal tissue narrowing or clitoral shrinkage. Vulvodynia formerly known as vestibulodynia. Vestibulodynia. Pudendal neuralgia, superficial pain located at the vulva, perineum, rectum, pudendal nerve distribution. There is a pain. There the pudendal nerve distribution. Pudendal nerve is very vulnerable. Compression and stretching injury during labor. It is very vulnerable to compression or stretching injury during labor, particularly an operative delivery with an extensive third and fourth degree perineal laceration. In perineal laceration during vaginal birth, uh, perineal laceration during vaginal delivery, a constant increases a vaginal delivery and constant increased pressure, fetal head, maternal pushing on maternal tissue causes vaginal, labial, and perineal edema. The vagina has an increased elasticity to accommodate the fetal head, but the other structures such as perineum and less elastic are more likely to lacerate. Perineal laceration often common in perineal laceration are common after vaginal delivery. It is more common, particularly in the primaries. Perineal laceration are classified on the basis of the depth. This is the next 10 page of this OBG and GYN flow. Hope you